My name is Eric Halsey. I'm a Senior Technical Advisor for Drug Use Epidemiology and Data at Vital Strategies. And we have been a partner for a few years with the MOP. And we're part of a Bloomberg Philanthropies Overdose Prevention Initiative, which is really a collaborative initiative, not only with the foundation or the philanthropies, but Vital Strategies, which we are a global nonprofit public health organization working on a variety of sort of primary public health, cancer registries, pedestrian safety, air quality, cardiovascular health. And with the kickoff of this initiative, domestically focusing on overdose prevention through a wide range of strategies. And I'm joined by my colleagues, Julie Vaughn and Esther Rosner, who are also here, who've been pretty instrumental in this partnership. The other partnering organizations in the initiative include the Pew Charitable Trust, obviously our colleagues at Johns Hopkins University, and the CDC Foundation, and collectively we're working on different strategies in several states around the country to improve overdose prevention. Next slide. So I'll kick this over to you, Jason, and we're going to share with you some of the results from this initial pilot phase of the MOP's ED MOUD initiative.
Thanks, Eric. And once again, I'm Jason Gibbons, postdoctoral fellow at Johns Hopkins and working on the Bloomberg Overdose Prevention Initiative. And we'll be summarizing our findings from the first phase of the evaluation. So as we all know, the United States opioid epidemic has claimed the lives of tens of thousands of Americans each year due to overdose. In 2020 alone, there were 68,000 in the US and 2,190 in Michigan. Hospital emergency departments have played a critical role in the overdose epidemic. They've been responsible for stabilizing patients and treating symptoms of opioid use disorders, but we also believe they can play an important role in overdose prevention by inducting patients on buprenorphine and referring patients to outpatient behavioral health care for follow-up treatment. Ultimately, expanding the role of EDs in overdose prevention can save lives and mitigate the growing severity of the overdose epidemic. So in 2020, the Community Foundation for Southeast Michigan partnered with the Michigan Opioid Partnership in a mission to reduce opioid overdoses in the state. As a part of this collaboration, a grant program was created that provided hospitals funding to improve OUD care in their EDs. Participants included a mix of health systems and independent hospitals. Specific grant objectives for participating hospitals included conducting an assessment to evaluate their initial OUD care capacity, training their providers to deliver buprenorphine services, developing a health system-wide implementation plan that included establishing site champions, holding regular consultations with physician champions to review all processes, and establishing a learning collaborative to share information about best practices with other hospitals. Other general goals in the implementation plans included increasing the number of buprenorphine waiver providers in the hospital, increasing the rate of buprenorphine inductions and prescriptions, improving coordination between the ED and the hospital pharmacies, and connecting patients with behavioral health care providers, which we call warm handoffs, and integrating patient tracking, OUD screening, and other support tools into electronic medical record systems. So Vital Strategies, in collaboration with Johns Hopkins, evaluate changes in care in the funded hospitals from the outset of the grant until the end of its first phase, to assess milestone progress and barriers and facilitators to change. Johns Hopkins and Vital Strategies surveyed hospitals before they began participation in the grant program, monthly during participation, and we also held key informant interviews throughout the grant cycle. Overall, we observed that the hospitals made significant progress in improving their OUD care, and the rest of this presentation will synthesize these findings in particular domains. First off, treatment initiation. All hospitals reported that they had worked to increase the comprehensiveness of their OUD treatment processes. The typical treatment process included stabilizing patients if necessary, and then screening them for OUD with a formal diagnosis. And then they would call in a specialized treatment team that included typically a mix of physicians, peer support, social workers, and other providers. They then discussed treatment options with patients, initiated them on MOUD, provided prescriptions for take-home buprenorphine, and referred them to outpatient care to ensure treatment continuity. Some barriers and facilitators to treatment initiation included issues with patient willingness to receive treatment. Many patients, especially those treated for an overdose, were often unwilling to initially accept any form of treatment. And those that were willing actually became impatient, often in hospitals, while waiting to obtain their medications and other treatment. However, some facilitators appear to be having peer support with social workers on the OUD treatment teams. They were very effective in getting patients to initiate care, and also broader coordination and expedited processing with hospital pharmacies, which reduced the likelihood that patients got impatient and left before receiving treatment. Now I'm going to present a quote from the field. So they'll come in and be triaged after they check in at the front desk. During that triage, they complete an expert screening with the patient, and then they'll get an audit score on their drug use and will be reported at that time too. So after triage, the patient will go to a room. They'll answer questions that they've given on that expert screening and are going to flag our peer support in our computer system. One of us will walk in the room and just say, hey, we're not a nurse or a doctor, but we're in recovery and we help people that may need some assistance in that area. And then we just kind of discuss with them their substance use, their history, their social history, and perform a brief intervention. And then we'll start from then setting them up with either outpatient or getting them set up with inpatient or an addiction specialist at that time so that we actually have a plan for them when they leave the hospital. And then we'll make that appointment for them. I will actually physically take them to their appointment, be there with them for their first appointments, and make sure that they get set up on an MAT program and that they're successful on it. And we'll continue with phone calls and things like that after people leave, also to keep them motivated. If the person who happens to be admitted to the hospital, we follow up with them on the floors every day that they're here. And then once they live in the community for 90 days, I'll be working with them on any MAT or anything else they need as far as recovery support goes. Moving on to the next topic, we have training and education. So providers across all grant recipient health systems and independent hospitals participated in one of 5 MOP official buprenorphine boot camps. These boot camps were MOP-led sessions that provided buprenorphine prescribing training to providers that attended. Overall, 223 providers were trained in the boot camp across 13 unique counties, and roughly 45% of attendees ended up attaining their X waiver. Hospitals noted providing other kinds of training and education to their providers as well. This included addiction stigma training, internal training, such as including binders of educational materials throughout the EDs to serve as a reference, circulating newsletters and other promotional materials to ensure broad provider engagement and awareness of practices in the hospital, connecting providers with peer support coaches to educate them on the lived experiences of people who use drugs, and educating patients. Hospitals created informational pamphlets that included contacts for community resources and mental health and substance use treatment provider contact information. Some barriers included the lack of time and availability among physicians. Trainings often took a full day and had a limited number of slots, making scheduling difficult in some cases. There was also some issues with stigma and perceptions. In particular, some providers had concerns about having to care for highly complex OUD patients, believed that buprenorphine offered minimal clinical benefit, were concerned about the treatment capacity of the ED, had beliefs that buprenorphine training was outside the scope of their practice, and also believed that other providers might decide to get the training, limiting their own need to get the training themselves. However, some facilitators to training included financial incentives, continuing medical education credits, framing trainings as a career development opportunity for more junior providers, and sharing the latest data on opioid use disorder rates and treatment. Now a quote from the field. We're in the very beginning of it, so we anticipate we'll have a subject matter expert training and then training for staff. What is opioid use disorder? What are the stigmas? What are we looking for? What is our policy and procedure going to look like? How we're going to be doing the MAT therapy or initiating that? So that's just some of the pieces that the education is going to be. Trauma-informed care is also another big piece. We use that in some of our other policies. And then just knowing that opioid use disorder is intermingled with a lot of other vulnerabilities that patients have, such as trafficking, sexual assault, domestic violence, child abuse, child sexual assault. knowing that it all can be tied in together and knowing that people have suffered on multiple levels and how we can help them during this trauma. Moving on to the next topic, buprenorphine administration and prescription. So a sample of 9 hospitals reported inducting over 450 individuals in MOUD and provided over 250 unique MOUD prescriptions. Prior to 2020, quarterly induction was roughly 15 patients per quarter, but increased to just over 20 patients on average after the program. Participating hospitals also accounted for between 40 to 50% of all buprenorphine inductions of Medicaid beneficiaries across the entire state. In an analysis of 3 grant recipient hospitals that treated more than 10 patients in the ED, between 39 to 90% of patients had previously received a dose of buprenorphine before their visit, while 10 to 61% were newly treated. Some barriers to buprenorphine prescribing included a lack of available local behavioral health providers for continuity of care, provider stigma against buprenorphine, and provider inexperience with prescribing. However, facilitators included creating buprenorphine order sets and integrating buprenorphine prescribing into electronic medical records, improving ED coordination with hospital pharmacies, increasing the supply of waivered providers in the ED, educating pharmacy staff on buprenorphine prescribing and needs to ensure a consistent supply of buprenorphine in the pharmacy, and having peer support coaches explain the benefits of buprenorphine to patients. Now, a quote from the field. There's a little bit of a learning curve happening with getting these prescriptions sent electronically and that sort of thing. But the providers have been so open and willing to speak with peer support if there is a patient that's in need of assessment for buprenorphine in the ED. And we really started to develop a good relation with them and talking to them about this because we're learning things from them and they're learning things from us. So it's been a really good team building experience. I know if I've got a patient that calls me and says, I'm in withdrawal, hey buddy, I'm coming to pick you up, then we're going to go to the hospital. And I know that there's somebody here that can take care of that. And that's life-changing. Our next topic is warm handoffs. All grant recipients noted that they made efforts to increase the rate at which they refer their patients to OUD care providers in the community. A subset of 10 hospitals provided over 500 warm handoffs to patients. The most common initial step to increase the rate of warm handoffs was to educate providers regarding their clinical benefits. Education occurred both internally by hospital leadership staff and also through the 7 learning collaboratives hosted by MOP. Some hospitals reported that they had integrated referral processes directly into their EMRs to streamline care. One hospital developed a set of QR codes for patients and providers to scan to help identify local community treatment options. And several hospitals also established follow-up guidelines for nurses and social workers to ensure that warm handoffs were successful. As far as arrangements with community organizations, there were both formal and informal arrangements, while other hospitals relied more heavily on PIHP coordinators to refer patients for follow-up care. Some barriers to warm handoffs included difficulties identifying high-quality providers who would continue to prescribe MOUD or offer induction services to patients instead of taking an abstinence-only approach. There was also substantial variation in quality across local community providers, and concerns over the lack of transparency regarding what services outpatient providers offered. Moreover, there was a lack of support staff to ensure patients were regularly scheduling follow-up appointments, and internal policies that required hospitals to have formal memorandums of understanding with outpatient providers slowed network formation. However, some facilitators included reliance on peer support and social work staff to help identify high-quality providers in the community. They were also extremely helpful in getting treatment-hesitant patients to consider obtaining additional treatment after leaving the ED. And hospitals that formed very strong bonds with community providers generally reported greater success in handing off patients to behavioral healthcare providers in the community. A quote from the fields. What's been helpful is having 1 or 2 pre-identified partners. They make it pretty easy for us because they send up staff. They send up a recovery coach who then can take the patient with them if that's what the patient wants, kind of thing. So it's been helpful having a community partner also be a stakeholder in this whole program and be invested in the ER and kind of understanding the ER side of things. The next topic is screening and tracking changes. So EMR implementation of screening and treatment tracking tools was a key change across many hospitals. Roughly half of all the participating hospitals made progress on improving EMR integration for OUD care. 6 hospitals noted creating buprenorphine order sets to simplify medication ordering and provide decision support. At least 1 health system created tracking tools for encounters that did not result in treatment to assess opportunities for treatment initiation improvement. And 3 health systems implemented technology that allowed them to conduct follow-up surveys for patients within 30 days of leaving the ED. Barriers to screening and tracking were poor user interfaces that complicated data entry, apprehensiveness in using tools among staff due to perceived burden, lack of conciseness of screening that led to lost patient interest and encumbering providers, the high costs of implementing these technologies, technical difficulties integrating specific components like the COWS or into the EMR, concerns over patient privacy and safety, and issues coordinating with IT staff. However, some facilitators included IT departments that offered 24-hour support services, physician champions helping to lead implementation efforts in the EMR, integrating buprenorphine into Pyxis, and obtaining staff on screening and tracking tools. Obtaining staff input on screening and tracking tools. Now a quick quote from the field. First, just getting the staff open to the idea of the screening and talking with them about their concerns has been huge. Second piece would be ensuring that the screening tool is short enough and concise enough that we're able to not only keep staff's interest, keep the interest of the patient as well, so that we're not getting too deep into the weeds. So that's one component that we're looking at with some of the screening tools that already exist out there, is how quickly can we get them through and how concise are they? And then another aspect would be ease of implementation with our EMR. The next topic is peer support. It's one of the greatest cited facilitators to improving all OUD care processes, with strong reliance on peer recovery coaches. Health systems with hospitals utilizing peer support coaches in general reported strong satisfaction and highlighted the strong ability of coaches to provide education to patients to initiate treatment. Grant recipients also mentioned that peer support coaches helped reduce stigma and educated providers on the lived experiences with OUD. Further, coaches were highly successful in improving care continuity and followed up frequently with patients after they had left the ED. Some barriers to peer recovery coach implementation was that peer recovery coaches were typically only available during daytime hours and unable to assist with patient care later in the evenings when overdoses were common. Coaches also faced scrutiny by hospital security when trying to enter the premises, and a lack of understanding on how to identify high-quality peer service organizations encumbered some hospitals. Finally, there was confusion over how to reimburse peer support staff delivering services. However, facilitators included finding reliable organizations with trained peers, and the best peers were those who were supportive of efforts to expand medication as opposed to peers that pursued abstinence-only approaches. A quote from the field. We're having a recovery partner come out and give us some education on stigma, motivational interviewing, and addiction, generally speaking. And part of that is having some of the more senior recovery coaches be a part of that discussion and talk about what the recovery was like. And they provide different perspective to the ER staff. We see a skewed population of people within the addiction spectrum, and we don't really get that many positive cases. We don't hear about people who were in the recovery and are successful. We only see and hear about people who have relapsed or have made poor choices. And we see the results of those types of choices and behaviors. So there's some burnout there as well. So kind of showing them a different perspective and kind of trying to get buy-in from them is part of the additional success with this. The last topic was stigma. So provider stigma was a barrier in all hospitals. Many hospitals mentioned that small but significant pockets of providers tended to discriminate against patients experiencing overdoses. There was also general apprehensiveness among providers regarding patient buprenorphine induction. Specific concerns of substituting one drug for another were often raised. And providers often preferred an abstinence-based treatment due to concerns over diversion and misuse of medications. Barriers to improving or reducing stigma included the provider inability to see outcomes post-treatment, the time associated with receiving additional stigma training that hospitals were providing, the lack of stigma training programs that provided CME credits, and general inaccessibility due to timing, especially following the pandemic, and contracting with low-quality stigma training programs. Facilitators to reducing stigma included free stigma training programs that offered CME credits and face-to-face meetings with peer support coaches to learn more about addiction. And final quote from the field. It's kind of almost built in the culture, almost of the AD, that these people have done this to themselves. That is a lot. It is choice-driven, and it kind of goes on from there. I would say one of the things that's been kind of helpful in an almost unfortunate way is that so many people are touched by this. So being able to draw kind of or relate on a personal level can kind of sometimes help change that. So maybe sharing of stories, those types of things. Also just the education that's out there as far as the physiology behind it, making people aware of the fact that it's not just a choice, that there's so much more that goes into it, and that these people truly want to help, and they're a vulnerable population. So definitely trying to break through the culture of the emergency department. But I think that people are just starting to become more open, especially as you see more of it in the news, just in the area, and people are relating to it personally.
Well, thank you, Jason. So I'm going to jump on here to talk a little bit about what we're hoping to do in the future. And when I mean the future, what we just heard of was for really the pilot phase period up until around October of last year. There's since been another round, and the MOP has really matured the interventions and the support that it's providing to hospitals who are willing to partner on this. So I want to just say a little bit about those future evaluation objectives and some other activities that we're engaging in. So next slide. So what you see here is some of the expansion beyond this period. So I think as of recently, we're up to about 49 hospitals who are actively involved in improving care in the ED over 8 PIHP regions throughout Michigan. Next slide. So what we're hoping to do, much of the same. I think what you just heard from Jason and some of the activities, I think will continue much of the same. And really, we want to, let's say sometime next year, hope to have a similar discussion with you to share out what we've learned and describe changes that occurred within hospitals as reflected by the completion of project milestones. And you'll hear more about that from Marissa in a few moments. That really are kind of the building blocks around effective care in the ED for opioid use disorder and some of the technical assistance that the initiative is being able to provide. We hope to summarize patient level exposures to some of the clinical protocols, many of those that you just had heard of. We also, something slightly different, which I'd say I'm presenting this with crossed fingers here. Hopefully, if we're able to secure some claims, we'd like to, share with all the participating hospitals and really to help further both, for internal and external audiences, some of the healthcare utilization post-ED experience. And that includes the buprenorphine fills, how many, how long since the discharge date, any readmissions, and that a lens around continuing care and engagement in community-based treatment, specialty substance use disorder treatment, or primary care, or wherever that person is seeking care following the ED. And underlined there in bold green line, really our hope is to share some of that interim progress along the way with the participating hospitals who are working with the MOP. Next slide. And something separate from this ED MOUD work, but or from the technical assistance that you've heard of up until this point, is that other component that Marissa had mentioned earlier is focusing on equity in care in emergency departments. I think, it's alarming to many of us that the experiences of fatal overdose are inequitable in many different contexts, in Michigan notwithstanding, and Black residents having much higher rates of fatal overdose by population. But secondly is also lower utilization of medications like buprenorphine. And so in an attempt to address that and some of the driving factors around that, both racism and stigma, among many other factors, but Vital Strategies and Community Foundation partnering with an organization called New Detroit that has developed a curriculum to educate. And I think it'll be, and Marissa, you could nod or shake your head if I say this incorrectly, but I think it's expanded not only to physicians, but other forms of prescribers, advanced practice professionals, et cetera. Okay, so the curriculum is aimed to increase provider knowledge around racial inequity in the response to the drug use, as I had mentioned, namely implicit bias, but also focusing on unique risk reduction and prevention strategies, building empathy, and a little bit around motivational interviewing. Those are just some of the components of the curriculum. And, following the actual educational training, we'd like to try and understand how these professionals plan and maybe change their practice as a result of these trainings, a couple of months following the training. So just wanted to give this group a little bit of an insight into other things that are happening as well. And I think that's the last slide.